Political presentations, that it's good to have your water readily available. I'm not going to put it over there. All right, then. Get my little clicker. And, oh, good, it's working. Well, I'm delighted to be here again. And here's something that happens to you when you age. So the developmental spectrum. 20 years ago, I probably would have spent last night memorizing my notes. I don't have notes now. Like, I am the notes. And so I'm not going to bore you with notes. I'm going to tell stories. And so instead of memorizing my notes last night, both of my daughters came back from college. One from Ursinus, which is in Collegeville, the other from Loyola, Maryland, freshman and a senior. So instead of memorizing my notes and worrying about my presentation, we sat down and we decided we were going to watch a serious movie. It's Oscar night. So we picked a serious movie called The Florida Project. Anybody ever see The Florida Project? So we saw The Florida Project last night. And of course, in my house, the way it works is you watch a movie only as a conduit for an argument. So we finish a movie, and we have there's 5 people in my house. And so my wife and my oldest daughter and my son, well, my son had a different perspective. He watched the whole movie, he's like, what was that about? And he left. So it was now down 2 on 2. So my oldest daughter and my wife got on one side of this thing, and my middle kid, my younger daughter, the freshman at Loyola who's taking film class, and myself, we organize ourselves to support the Florida Project. And so we're getting into this argument. My older daughter, who's a very linear thinker, she's a history major, she likes to see the thing kind of organized and see the theme kind of be evident. So she's arguing with her sister. And her sister looks at her, and she says, and this has been going on for a long, long time. She says, "You don't seem to get it, do you?" I said, "What do you mean?" Like, the whole movie was shot from the perspective of a child. So if you're wondering why the theme isn't obvious, why what's going on is not evident to you, it's because it's shot through the eyes of a child. And I thought to myself, like, we wouldn't have had this conversation 10 years ago, because I don't think developmentally people wouldn't be able to do that. And I thought to myself, all right, let me do something that I would do at 54 that I did not do at 34. So this morning on the drive up, I changed my entire talk. The whole talk is now going to be shot through this lens of whose perspective is it? Whose perspective is it, and what are the implications of that for your treatment? So the Florida Project is now my organizing theme. Which there's no way I would have done 20 years ago. I would have been sitting there memorizing stuff. I don't do that anymore. I don't need to. I remember 10 years ago, maybe. Doug Woods, anyone ever see Doug Woods present? So Doug Woods is I think, the world's expert in the behavioral treatment of Tourette syndrome and trichotillomania. Just astounding intellect and a really good presenter. And he and I had put a presentation together because we had a bunch of NIMH officials. Both of us had big grants on the table, and the NIMH officials were coming to our conference. So I took a lot of time putting the talk together. I gave it to Doug. He said, give it your spin. We're actually in the hotel. We're in the gym, little fitness room. So he says, come on down to the fitness room. I want to chat with you about the talk. And I'm thinking, the thing is tight as a drum. What could you do? So he's on the treadmill. I said, so what'd you think? I said, well, I liked it, but it was a little dull. Oh, okay. So what'd you do to it? I organized it according to a Rocky theme. Like, what? You did what? So I get a little bit of Rocky stuff going on in there, which as a Philadelphian I should appreciate. And I trusted him. So, okay, fair enough. He gave the talk, and it was really good. I think the Rocky theme saved it from being dull. So I hope the Florida Project saves this from being dull. And if it doesn't save it from being dull, please let me know. Like, vote with your feet. Just leave and let me know I need to do something different. But I'm going to tell stories, essentially. Okay? Who's ready for stories? Good. All right, this is a boring story. Okay. Obsessions, unwanted thoughts, images, give rise to anxiety, distress, disgust, discomfort, call it what you will. And what you call it matters. What they call it matters. If they're telling you they're uncomfortable, they're telling you something about what you do and don't want to do in terms of treatment, which I'll get into later. Obsessions give rise to anxiety. Compulsions reduce it. Most people who are anxious get anxious in response to thoughts. They don't like the feeling, and then they try to avoid. In OCD, we get like a special thing that people do. It's like a more active form of avoidance. Compulsions. I touch something hideous, right? Now I'm in the middle of a large group. I can't run out and wash my hands. I might do something like this. Put my hand in my pocket and rub it on the inside there, and I get the contamination off me. So, touching the hideous thing, obsession, gives rise to anxiety. Do a compulsion, pull my hand out of my pocket, and I feel a little better. Relief. Yay, relief. We all want relief, don't we? Isn't that a good thing? No, it's not a good thing. Negative reinforcement. So now I've just set myself up. The next time I touch something like this, what am I going to want to do? Fix it. And now I'm onto that treadmill. Tough to get off. So we'll get into that in much more detail, but that's sort of for most OCD, it fits into this story. Now note that there's no arrow leading from here. Okay? What causes obsessions? People ask me that all the time. What causes my obsessions? Why do I have these obsessions instead of those obsessions? And my answer is kind of an academically nerdy one. So I'll say, well, the factors associated with onset may or may not be the factors associated with maintenance. Well, what the heck does that mean? And you know what that means? I don't know, and I don't care. Because if I can change this, you're going to see over time, not in the beginning, you're going to see an increase in anxiety. If you think about it, I touch something like this, now I want you to sit with it. Right? And as I get you more used to this, I don't want you to just sit with it, I want you to push the envelope. Lean in. See that? Pretty good. A little lemon to it. Let me add something else. I know. The med students hate this one. Because med students know what's possible, but they don't pay a lot of attention to what's probable. What's probable from this? Besides a couple of squeamish looks, the disgust face that Lars Ost talks about. Lars Ost treats all sorts of animal phobias. And he looks at this face like this. That face. It's a form of avoidance. All right, cheers. There we go. Do I look anxious? But it doesn't matter. I'm not anxious. I've just confirmed this over 27 years. But the person who has contamination fear, I don't expect them to look like me. Yet. So will we do it once or will we do it 1,000 times? 1,000 times. I'm going to get into softball and baseball and stuff later. So I like to talk about that stuff. You teach somebody how to bunt. I coach. First thing you got to get a kid to do, I'm a lefty, you got to get a kid to be comfortable turning their entire body to the pitcher. Customarily, you're like this. Ball comes at you, you just turn away. Here I'm asking somebody to do this. Right? Watch your bat angle. Flat bat, it's terrible. Up. How do I get people to do that? Do I just tell them? Or have them do it a lot? Anybody? A lot. A lot. And I do a thing called successive approximations with bunting, which means I don't care where you bunt this ball. When I'm first teaching you to bunt, I couldn't care less. You can pop the ball into space for all I care. Good job, good job, good job. I'm reinforcing you for taking the first steps. Then when you can, I do it mathematically. When you get 18 out of 20, now I'm going to get picky. Oh, you only get a good job for getting the ball on the ground. Good job, good job. If you bunt it in the air, I say, okay, bad angle. I give you some quick feedback, but not belaboring it. Good job, good job, good job. 18 out of 20, good, let's keep moving. Now I want you to bunt it to particular places. Third base line, first base line. And that's much harder. I'm going to do hundreds of repetitions, hundreds. And the kids who really want to learn this are going to come to me before practice and after practice. And if you're the kid who comes before and after practice and works at it, guess what? I'm going to trust you in a game. If you just did it in practice 20 times, you popped up half the time, I can't put you in that position. I can't put us in that position. So you got to put the work in. We just keep working at it, keep working at it. We understand the anxiety in the game is going to be higher than in practice, so we just keep working at it. Keep working at it. We simulate games in practice. Keep working at it, keep working at it, keep working at it, move up. And it's up to them, largely. I'm reinforcing them for making effort, but people don't want to work, then not a lot we can do. They're not ready to work. It's another issue, which we'll get into. All right. So that's my treatment, essentially. Have an obsession, be anxious, don't fix it. There's your treatment. 430-page manual I just finished. That's what it says. Have you ever seen The Shining? Jack Nicholson? All work and no play. That's what it is. I put other words in there just for fun, but the reality is that's what it is. That's all it is. Make the complex simple. If you're working with kids, you better be able to do that. Even with adults, we're just having this conversation. Like if I say to an adult, blah, 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 habituation curves, blah, 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 decay slope. What? It's a decay slope. So you got to be able to translate. And hopefully your patient can say, that's one thing I love about kids. If I use my nerd words, as my kids at home say, and the kid doesn't understand, they say, I don't know what you're talking about. An adult will do this. Yes, doc, I got it. And they come back the next week having done the wrong assignment. I thought you had it. So I got to make sure you have it. So I'm going to check to make sure you understand what I'm talking about. I'm not letting you leave my office until I know that you know. Because essentially what my goal is my own obsolescence. I want you to get rid of me. I want you to fire me as quickly as possible. Because you got better stuff to do. It's expensive, it's a pain, it's a long commute. You've got to come into West Philadelphia, for heaven's sake, find a parking spot. Like if you're a kid, I'd rather you be climbing a tree. But you're going to be climbing a tree more effectively if you know what to do about your OCD. So that's what we're doing. Trying to get rid of myself. Okay? So, kids, not surprisingly, may be less likely to describe their feared consequences in detail. I don't know, it just feels icky. Sometimes you get the disgust face. They can't really tell you sometimes. Sometimes they can. Depends on the kid. But if they don't have a story, I wouldn't spend a lot of time trying to bash the story out of them. Tell me what it is. You must know. No, you don't. And if it's not just right stuff, I got to touch something on the left to fix it on the right, there may not be a story, even with adults. That's a little bit more tick-like. It's discomfort. And if it's discomfort, it's going to have some implications for what I'm doing and not doing. Kids, of course, going to bug their families, right? They're more comfortable with their families. They're going to ask a million questions. They're going to get very, very good at asking these questions. Sometimes it's about their persistence, sometimes it's about their cleverness. So I got a kid who sometimes will do this. So things are going to be okay. And he like stares at mom. And now it's like he's playing poker in Vegas. He wants to see if there's any facial expression suggesting otherwise. So he's essentially, without asking a question, he's asked a question. And you've answered it by going like this. Right? So now I get relief. And remember what relief is? Provides negative reinforcement. It's gas on the fire. You just put gas on the fire. It may make you feel better. Temporarily, it may make the kid feel better, which is why you feel better. But guess what? We got to get you out of it. And you don't have to get out of it in a mean way. We'll talk about that when we get to the kid stuff. But certainly, school, very interesting. I think I have more than my fair share of 13, 14, and 15-year-olds who are afraid of turning into another person. I don't see that much at 7. It's rare I see it at 7. I see it at 13, 14, 15. And I see it then because guess what? What's the developmental challenge when you're 13, 14, 15? Figuring out who you are. And sometimes I got some academic kids that say, I don't want to be like the kids who don't study. Other kids, I don't want to be like a kid who's uncool. So kind of whatever that kid in particular is worried about, OCD says, oh yeah, how about this? How about they might have brushed against your backpack on the way out of school? I have an obsession, I'm anxious about it, I want to get rid of the obsession. What do? I wash my backpack. Or I don't use my backpack. I need a new backpack. Looking at the backpack, it looks pretty good. I bought it like 2 weeks ago. Why can't you use it? Well, I just can't. I need a new one. And sometimes a kid will flat out tell you. Sometimes you'll know. But sometimes you're sitting there replacing stuff and you don't know why. So as a therapist, you want to find out the why. Right? So I'm looking for those sorts of things as I go. Kids, little kids certainly tend to be more magical, but I do see this turning into others' piece as being a little bit more associated with adolescence, young adolescents. I also need to know what you know. Like, what do they know? I'm afraid I'm going to get sick. Like, if you're 9, you may or may not know how long germs live outside the body. And some kids are like, well, do you realize that once the thing is out, it's out? Most of the time, it's going to die. And some kids are like, didn't know that. Okay, so I can put out an anxiety fire with knowledge. Sometimes the kid says, well, I did read that on the CDC website, but I don't believe it. It's a different issue. Kids get clever. They know the interwebs better than we do. My son is a whiz. He can find anything. And I want to know what they know before I start assuming it's an obsessional theme. It may just be lack of knowledge, but a lot of times it's not. All right, I won't bore you with this too long. Let me just suffice to say, there's a thing called the Yale-Brown Obsessive-Compulsive Scale. It's used in adults, and what you do when you use it with kids is you slap on children's. Same thing. But how you frame the questions is developmentally driven. Right? So on average per day, over the course of the last week, how much time do you think you spent obsessing? Ask that to a 9-year-old. What? Like, I got to find a better way to say that to a 9-year-old. Now, it's the primary measure of outcome, which we'll get into in a bit. It runs from 0 to 40. I don't believe in 0. I don't. No such thing. There are no zeros. Especially people who have a vulnerability to OCD. Somebody tells me they're a 0. I've had no obsessions and no compulsions this week. You're trying to dodge me, aren't you? You're trying to get out of here. So I'm going to pay attention to that in my treatment. Need a 16 to be considered clinical for some of these trials I'll talk about very briefly. Suffice to say, though, how I ask the questions of the adults is going to differ from how I ask them of the kids. And I'll try to give you some detail. This is what you're asking. separately for obsessions and compulsions. If I'm talking to a 7-year-old or even a 5-year-old, I'm not going to ask the obsessions first. I'm going to ask the compulsions first. What behaviors? And I'm going to often ask that question of the parent in the presence of the child, if they're 5. And I want to find out what the behaviors are. I can work my way back to the prompts. If I'm talking to a teenager, though, I think I can usually get away with the same thing I do with adults, which is ask the obsessions first. How much time do they occupy? How much do they interfere with functioning? How much subjective distress? You ever ask a 10-year-old how much subjective distress they're experiencing? What? Good for you. Call me on my nerd words. How much does this stuff bug you? When you do touch something and it does feel icky, like how much does it bother you? How much does it get in the way? Does it stop you from doing stuff? It's the same question. But subjective distress can be chucked because I'm trying to relate to a kid. Understand it's their perspective. Florida Project. It's the perspective of the kid. If I'm asking a kid a question, I better be able to frame it so they can answer it. So I got to be flexible in my language. Resistance and control. Resistance of compulsion. Everybody has to understand. Because if you're trying to do this treatment and people don't have a good idea of whether they're resisting their compulsions, you're in trouble. Item 9 on the PSI box, the Y box, which is resistance to compulsion. The most important item. If I don't get that thing down to, it's a 0 to 4 scale. 0 is I resist 100% of the time. I don't believe that. I don't believe that at all. A 1, most of the time I try to resist. And this number 10 here would be that I'm successful in resisting. Trying to resist is one thing, being successful is another. But in the beginning I need people to start saying no. OCD says jump. If you're saying how high most of the time, you're going to have a worse OCD problem. In the beginning, when you start doing the treatment, when OCD says jump, you tell it to buzz off, guess what? You're going to be more anxious. It's going to be more anxiety provoking. Sometimes kids will say, well, it's not working. What do you mean? Like I say no and it gets worse. And my response to that is, who said it was supposed to go away right away? Who said? So I want to understand that so I get the kid's perspective. I want to get them to understand this is going to be a while. Training an athlete, you're going to be sore. Sore after practice. I'm in Giants country. There's a fellow here by the name of Jim Burt. Played for the Giants in the mid-'80s. And he was a Buffalo native. I was playing my college football up in Buffalo. And so Jim Burt would come in the off-season, he'd sit around and watch us lift weights. I can recall as a freshman, walking out of the weight room, like sauntering out on my way, and just feeling fabulous about this whole thing. And I got stopped by Jim Burt. Jim Burt is like this big. So Mr. Burt it was. Hey, Franklin. Yes, Mr. Burt? So you're looking good. You're looking lithe, you're looking smooth. You're going to play some basketball, huh? I said, yeah, I think I might. And he does one of these. He says, when you leave this weight room, you're supposed to crawl out of here. I watched your workout. You did everything, but you didn't push yourself. You want to get better? You got to be sore. Ha! I just got insulted by an NFL player, which felt like a compliment or something. But it's true of music too, right? Come to the piano teacher. She knows right away. Oh, how much were you working with the piano this week? Oh, yeah, I looked at it a little bit. I can tell. I know. And I know, alternatively, I know who's doing the work. I can tell. So the action in the treatment isn't always right smack in the middle of the exposure sessions. So we'll get into that. But basically this, getting them to resist their compulsions is the first step. Teaching them why and then getting them to do it. Vigorously encouraging it. Okay? Just organizing theme for later. 16 is relatively mild. Most people come in around the 18 to 29 range. This is pretty severe. I see somebody at 30 or higher on the Y box, I'm already thinking about higher levels of care at pre-treatment. Okay? So, sort of what I've been saying. Watch your language. Make sure you're checking things. And I tell kids flat out. I say, look, if I'm using nerd words, you got to call me on it. Because if you don't understand what I'm saying, then we're going to have a problem. I want you to understand this as well as I do, so call me on it. And one kid, he was kind of happy about this. He goes, nerd word. Okay, thank you. Appreciate it. Let me try that again. Make sure I'm making this sufficiently flexible. This depends on age, also depends on how chatty the kid is. I can have some 10-year-olds that asking the questions of the parents. I have some 7-year-olds who come in wanting to give a soliloquy about their symptoms. So, I'm flexible, but in general, the younger the kid, the more I'm going to be asking the parents the questions and saying, does that sound familiar? Whereas with an older kid, ask the kid and say, and sometimes you get this. Kid tells me, I'm washing about 10 times a day. And then you see mom going like this. And I'll say, it sounds like mom thinks there might be some more. And instead of having it be an argument, I said, look, sometimes parents are pretty good. They watch kids like hawks. It's our job. So they might be better at knowing the behavioral side of this. You may be much better at knowing the kind of the obsessional side. So how about we try to figure this one out? I don't want to fight. I want to get the information. Okay? Sometimes you get a kid who sits down in your office. Oftentimes it's a teen. Right? You start asking the parents questions and the kid's like this. And his lips disappear. How much is your OCD bothering you? Not much. And he's a ventriloquist. Not much. It makes me suspicious. We have a coffee shop in our building at Penn. Like, this might be a really good time for you two to take a coffee break. And maybe you can bring your kid a water or something. Take your time. All of a sudden the kid's like, now if the kid's still exactly the same way, I got to figure out what's going on here. But sometimes I got to figure out if speaking about the symptoms in the presence of the parent is too much, I'll find a way to make it more flexible. And I got to make sure that fights don't break out. Make sure that people aren't arguing and screaming at one another. That's my job. I need to get valid information. And if I'm not getting valid information with everybody talking, I'll take over. It's my ring. I'm the referee. If I need you to be quiet for a minute, I'll let you know. I'm good at it. As a therapist, you got to get good at it. Otherwise, your sessions become family feud and not in the game show way. And you wind up not getting the information you need. All right. OCD sometimes occurs with other stuff. I got to know what the other stuff is. Okay? Most of the time, you're going to see a second disorder or constellation of symptoms. Even disorder, I don't even like the language anymore. Other symptoms. Besides OCD. You've got to make some decisions about what's the primary thing to work on. In both kids and adults, another anxiety disorder is the most common comorbidity. I'm looking at adults though, depression kind of starts sneaking up there, maybe 50%, 60% of adults with OCD have comorbid depression. And sometimes it seems like it's just flowing from the OCD, sometimes it's got a separate life of its own. You've got to evaluate that. But regardless, if I have somebody who's so depressed they can't do the treatment, even if the treatment or the disorder of OCD is causing the depression, I still have to make a clinical decision as to what I'm doing. And sometimes that decision is I'm going to treat the depression first. And sometimes people aren't happy about that. I get that argument. I'm like, look, if you can't get out of bed, you can't make it to the treatment session. This session was scheduled at 10 a.m. and it's now 11:45. This is not conducive to making the treatment work. So maybe we need a higher level of care, maybe we need treatment for depression first if that's the case. So, with kids, ADHD, oppositionality, things like that you'll see. With adults sometimes you'll see substance use. It's not a terribly high comorbidity rate, but when you see it, you better be dealing with it. People are taking a drink at the end of the day to calm themselves down, and after a while that drink turns into 3. Now, it may not be 47, but it's still in my way. Because I got a person who's trying to calm themselves down, and instead of doing compulsions, they're having a drink. What's the difference? I still got a problem. Okay? And treatment selection and comorbidity. If the comorbid condition is more important, I got to treat that. Sometimes I can get away with doing 2 birds with 1 stone. So I can treat the OCD and say, well, as this applies to your specific phobia, let's see what we can do about it as well. But with depression and things like that, externalizing conditions, oppositionality is one where I feel like I need to get parent training on board before I can do the OCD treatment. That's a good example. Now, you will not suffer. I'm going to show you research slides. Please do not avert your eyes. All they are stories, I swear. Okay? Stories. And they're important stories. Okay? Because it's about what do we know about treatment? What do we know about the various treatments? What do we know what happens when we combine them? And what are the implications of that for making clinical decisions? Now, what did I tell you about the psi box and the y box? 10 to 15 point reduction for CBT. And that's CBT done weekly or twice weekly or sometimes even intensively, depending. Depends on the study. So a 15-point reduction means if you came in at 28, you have a 13 by the time you're done. It's pretty good. Subclinical, yay for us, yay for you. Okay? That's what I expect based on 30, 40, 50 studies over decades of work. Generally speaking, when you stop CBT, you maintain your gains. Not perfectly, but the majority to the vast majority maintain their gains after finishing a course of CBT. And if you start to slip, you come back in, we do some boosters, get the ship righted again. Okay? So that's what we expect. Downside is it's anxiety provoking. So somebody says, I'm having horrible intrusive thoughts and I need to get rid of them. And you say, well, we're going to write stories of those horrible intrusive thoughts. We're going to write them like Stephen King and Edgar Allan Poe. We're going to record them and have you listen to them. And the person's like, what? You're going to do what? You're afraid of contamination? I got a dumpster behind my office. It has a ladder. It does. I told this story recently to I was presenting at the Department of Psychiatry at Penn. And I said, if you happen to see myself and a child standing out behind the dumpster, behind the office as you're getting out to your fancy cars, have no fear. I'm just doing my job. My meager salary is not the reason I'm out here. So, but some people decline. 20%, no thanks. I'll find something else. Let me do relaxation. I love relaxation. Let me do anxiety management training. That's even better. It'll make my anxiety go away. Guess what? Doesn't work. It's the control treatment in a bunch of our trials. We don't think it's going to work. Works a little. Depends on the person. But my educated guess is relaxation strategies, though they might help you fall asleep, they're not going to help you reduce the frequency and intensity of your obsessions or your associated compulsions. It's not what we do. Because of science. Science forces our hand. So, meds, not as robust a response. They're better than fake medicine, which is good. You want to be better than fake medicine. And consistently in OCD, we see that. And if you stay on your med, typically you maintain your gains. There's some bumps here and there, some poop-out effects over years for some people, but for the most part, maintain. Downside, clinically significant residual impairment. which is a nerd word way of saying if you started out at 28, you came down 8 points, you're at 20, which means you still have clinically significant OCD. So, relapse upon discontinuation of med if you don't put anything else in there. And if you want to come off meds or you need to come off meds for some reason, you do tend to see the return of symptoms if there's nothing else in there. And then side effects for at least some who can't get to therapeutic doses. So that's SSRIs alone. Serotonin reuptake inhibitors for those keeping score at home. Now, in terms of how they compare to one another and to combined treatment, study that we did in 2005, placebo is fake medicine. As you see, not a lot of change. Y-box, the higher the score, the more severe your OCD is. Clomipramine, tricyclic antidepressant with serotonergic properties. Not usually your first choice in clinical practice because of the side effect profile. You're usually going to go with an SSRI. But in this trial, which was done a long time ago, we use clomipramine. It is different, significant, but if you do 2 hours a day, 5 days a week of CBT, exposure-based CBT, look where you wind up. 10, 11. And absolutely no difference, which is interesting, between exposure, ERP alone, and combined treatment. And this treatment is over by week 4. 2 hours a day, 5 days a week for a month. And people maintain their gains in general. So we didn't get a combined treatment effect here. But we're not the only people who've done this. I want to show you a few more. Remember what I said about stress management training? Relaxation? Let me do things to calm myself down? That's what this is. Not a lot of change. And it didn't work compared to twice weekly exposure plus response prevention. So we don't recommend that typically. This one I thought was pretty interesting, and it doesn't show up so well. Exposure and response prevention, twice a week. Y-box is 26 to start. It comes down to around 12. So 80% of the people meet our response criteria. And the remission rate, OCD less than 12, was pretty good, almost half the sample. Absolutely no difference between placebo augmentation and Risperdal augmentation. These are for people who are on an SSRI when they came in. So if you add Risperdal, you get nothing, which was a surprise. We expected it to be better than that, based on another trial. So this kind of throws a monkey wrench into some of the recommendations. I'm going to skip this. This is boring. Boring. Okay. Combined treatment doesn't seem to impede the individual treatments. It's not worse. It's not like you put two things together and it blows up. It's actually either better than or equal to. It seems like it's not consistently better than CBT. It depends on how it's done. But there are some trends evidence. Kind of a point in the direction. I think combined treatment is a perfectly reasonable option. And it seems like it augments the use of, when you're on medicine and you come in, you can add CBT and get further reduction, which is good. Now, let's look at kids. Same slide, right? Pretty much. All the same, except for this. The black box warning came on in 2005, I think it was, where there was a slight increase in suicidal ideation in kids on the SSRIs versus kids on placebo. But if you really look at that data very carefully, it was a 3% increase versus a 1.5% increase. And because the sample size was so large, that 1.5% difference was significant statistically. Now, I think it's a good idea if you're going to put a kid on an SSRI that you're careful about it, you're attending to this. But I don't think this is a reason, for me, this is not a reason to not put a kid in an SSRI who's got OCD and comorbid depression. I think that's too risk averse, and the irony of it is the very thing that they now have and you're not treating with med might be associated with some of these outcomes anyway. So I'm cautious about the black box warning, ironically enough. But I don't prescribe, so this is all for my psychiatry colleagues. Now, We've got multiple trials. I'm not going to spend a lot of time on these studies, but suffice it to say that we got good evidence for CBT now in kids. This question comes up a lot in the clinic. Does my kid have to be on a med in order to respond to CBT, or will medicine interfere with CBT? And the answer is, these are kids, this is a study we did almost 20 years ago now. CBT alone versus kids who came in on medicine, we had CBT. Nice reductions in symptoms, good maintenance of gain out to 11 months, and there's no difference in these two groups. So it looked at the very least like you don't have to take your kid off medicine to benefit from CBT. Same exact finding in UCLA, John Passantini. So this is encouraging, but these aren't randomized. The kids came in on the medicine. One randomized study I'll show you. So, fake medicine again doesn't get you much. Combined treatment was quite good, like 27 to about a 10. It's pretty good. And that's weekly CBT. And weekly CBT and sertraline surprised me, us, that the CBT started out a little bit higher, but they wound up at the same place. So weekly CBT was comparable overall to the effects of sertraline. A little bit of a surprise. When you cut it another way, you're looking at how many people are 10 or lower on the psi box, which is subclinical symptoms. 55% of the kids in combined treatment, 40% of the CBT kids, 10 or down. So if you respond to CBT, you're more likely to respond robustly. Only 1 out of 5 kids on sertraline and 1 kid in the whole trial responded beautifully to fake medicine. Interesting finding. And now this one really is going to mess us up. A site effect. I got a site effect question earlier, even before I got to the podium. So, in this case, this is a between subjects effect size. So we basically subtracted out the placebo effect. So the bigger the effect size, the better the treatment did. So in this case, Penn and Duke. Combined treatment looked, and an effect size of 1 is pretty big. It's good. Penn and Duke did quite well on combined treatment, and they did comparable. Medicine, a slight home court advantage for Duke. They were the medicine site. And they did their medicine did slightly better than our medicine, which is interesting. Now, I ran this graph at like 10 o'clock at night in my office. It was like watching it was like watching It. Like the clown in the sewer. But I did not want to see this. This surprised me. We did a lot better in our CBT. And the question then is why? It wasn't that our patients were less severe. It wasn't that, it had nothing to do with patient quality. It had to do with 2 things. First thing it had to do with is how far are you going to push people. And I'm pretty comfortable with that, and I did a good chunk of this treatment myself and also supervised it at our site. So how far are you going to push people? And I don't mean like yell at them. I mean like I'm talking about with Bunny. How hard am I going to work you? How ambitious am I going to be? The more ambitious you are, the more likely it is you're going to get this kind of response. The other thing we saw, which is fascinating, this is a paper we have under review right now, is what does the therapist do when the kid declines an exposure? We coded all these tapes, and here's what we found. If the kid says, I'm not doing that, and the therapist slowly backs out of the room, I'll never ask you to do anything like that again, forgive me, you're going to be a non-responder. If the therapist backs up 2 steps, I apologize, that's too hard. But what can we do along the way that's going to get us to where we need to be? So they back up, but they don't back down. The Tom Petty effect. Stand me up at the gates of hell. I'm not backing down. I know we need to do this. I just got to find a way for you to get there. Back up, but don't back down. That's what's driving this, which is useful to know. All right, my boyhood hero, Tom Seaver. Pitching CBT. How do you pitch? How do you get people to do this? You want me to do what? How do you get people to do this? Talk about it. Depends on developmental level. Also depends on who I'm talking to. If I'm talking to a 40-year-old, I can have a kind of a rational discussion about how much it's affecting their family, their functional impairment, etc. If I'm talking to a kid, it's going to be a different discussion. So let's just look at the adult discussion first. I start with the outcome data. I summarize all this stuff and I basically say, here's what we know. Here's what my educated guesses are. Now, no outcome trial on earth, I don't care how big it is or how robust the outcome is going to tell me how you're going to do. That's a guess. But we also know there are factors associated with better outcomes, we call moderators and predictors, and they may too have an influence over what we're going to recommend. Okay? I'm going to give you the theoretical rationale. I'm going to break out that slide. The negative reinforcement slide, I show that to people who are thinking about this treatment. Let me explain how this works. Let me explain what we expect. I tell them up front. Telegraph. Talk about these factors. Looks like you got depression, but it sounds to me like it's mild enough where we could still go ahead. Or not. Or it sounds like you're not quite ready to do this. That's okay. I'm not going to make you do anything. I'm going to sort of make you aware of the consequences of choices, though. But then in the end, you get to make the choice. And I'll tell them what we might do in their specific case. I explain, this is with adults, that if you do your compulsions, you're not going to see that anxiety would come down. If you do your compulsions, you're also not going to see that the feared outcomes don't come true. I know I'm going to get the flu if I do this. Well, you might get the flu anyway, but let's find out. Let's take a risk and find out. Functioning immune system is a good thing. And Purell, it's the devil's liquid. It's not moonshine, it's Purell. That stuff will keep you functioning okay, but you're still ritualizing. I always make a big deal out of throwing it out. A dramatic ceremony in my office. It's flammable too, I've learned that. That's kind of fun. I wouldn't recommend that in the office. So basically, I like this quote for adults. When you value your comfort over your functioning, eventually you'll have neither. So my dear friend Paula Young is now in Chicago at the Rogers site. She was moving offices, and she said in the bottom of her drawer she found a little sticky note that said that. And apparently the sticky note was her writing down comments I made in a supervision, like 20 years ago. And she's like, this thing's been in my office for 15 years. I'm like, huh. Every once in a while you hit one. But that's what you're looking for. Because people are going to say how awful the treatment's going to make them feel. And I'm going to tell them, well, that may be true for a while. I can tell you, though, what you can expect if you don't do it. And I just drag out the data. And then people make an informed choice. And I'm not mad at them either way. It's up to you. So, I like this slide. So what happens basically is exposure to something, you touch something, or you leave your house and you're not quite sure if you turn off the oven. Now what? Well, if you go back, and indeed the oven is usually off. You get some temporary relief from seeing that, but then the next time you're in that situation, you want to go back and check again. Negative reinforcement. And you get stuck in this cycle. Alternatively, the oven again, I decide, this is probably my OCD talking, I'm not going to give in. I'm going to tolerate it. I'm going to go about my business. Right? I'm going to wait till 12 hours from now when I come back home and the house is still standing. There's no fire department putting things out. And then the next time, it helps me gain the strength to do that again. And over time, that process becomes easier. So I'm telling my adults. Some of you have seen this slide. This is a lesson in humility from a 6-year-old who's now 22. So I'm going off to do a 3-day BTTI workshop, train therapists. And my 6-year-old is livid, just beside herself. Because it's a soccer weekend. She's got a game on Saturday. And she played 6-year-old soccer as if human lives were at stake. Everyone else was sort of milling about the ball. This was life and death. This is the World Cup. So I was going to miss the World Cup. And she was mad. And she says to me, "You mean it's going to take you 3 days to teach people what you know?" She squints her eye. It's a genetic thing. We call it in the house the dismissive squint. What you know? Which you don't have 3 days worth of any information, pal. And I'm very good at ignoring tone. But she also got me interested intellectually. Like, really? So you don't think it's going to take 3 days? I think this stuff is pretty complicated. And she goes, "No, it isn't. If you said it in one sentence, you could say it on Friday and come home, and you wouldn't miss my game." And I said, "Well, now I'm falling over myself. Like, what do I do now?" So I said, "Well, what sentence would that be?" And in order to more dramatically make her point, she jumps from the floor onto the coffee table, sticks the landing perfect, sticks her hands on her hips, breathes in as if to mock my speaking style. She's right. We can make this complicated if you want, but she's right. That's it. Do the thing you're afraid of, assuming it's not dangerous. They already made it more complicated. Just do the thing you're afraid of, and the more you do it, the easier you'll get. Okay. Next. Are there any of the world's ills I need to solve now? How about world hunger? She was not lacking for confidence, we'll put it that way. Still not. But she's right. So whatever the heck it is that you're doing in treatment, whatever the heck it is that you are following in treatment, depending on which side of the aisle you are, there you go. You gotta do the thing you're afraid of. You gotta lean in instead of away. Right? I used a hockey analogy not too long ago. If you're back on your heels, right? Which way are you gonna be skating? You're skating this way. You gotta be on the balls of your feet. You gotta attack this thing. Attack. You need a plan. You might need a coach. You're definitely going to need cheerleaders, but you've got to be on the attack. Lean in, not away. Because, and you can translate this for kids too, if you value your comfort over your functioning, eventually you have neither. It's going to cost you. You can't keep backing up. At some point, you got to hold your ground. Okay? Now, other ways to put it, gets a little more abstract. I use this more with the adults. Let the obsessions go, don't try to make them go. Now we're getting into all sorts of things like ACT, which I won't describe in excruciating detail, but suffice it to say that most things in life will come and go of their own accord if you let them. There's suffering and the temporary relief from suffering. Don't try to push them around. Don't try to have more or less of one or the other. Just radical acceptance. Oh good, I have an obsession. Cool. Fabulous. Now, what was I supposed to be doing today? Okay, let me go do that. Obsession, come with me. You're fine. Come join me. Come and go of your own. But you're not getting my agenda. Can't let the thing drive. Another analogy I've used with teens is you learn how to drive, you can't give the wheel up to other people. Let the thing sit in the back and chatter at you, but you can't give up the agenda. This is your car. Drive it. Okay? Now, this is my oldest. In a playoff game her senior year. This is her pitching in another playoff game. She's a second baseman mainly, too short to pitch. I have another, my middle kid is a pitcher. So I put this picture in here of her like firing a ball. A bigger girl and stronger. And she looks at my slide set. I should never let her do that. And she's like, you can't use that picture. Like, why not? She says, because I look like an MMA fighter. I'm like, well, what's wrong with that? And she just shakes her head. She goes, you don't know anything, do you? It's a different kid, same attitude. Attitudes, we call it in Philly. So I switched it out. But I'm pitching to kids. So now I got a kid in my office. Who am I talking to? Am I talking to the parents? Here's what you should make her do? No. I need her. You can't make people do anything. Right? You can encourage, you can entice, you can educate, but in the end, it's hard to make people do stuff. I need the kid. So how am I going to pitch this to the kid? Heck with the parent. Their metaphors, age-appropriate language. What does this kid like to think about? I was doing an intake once, and I'm asking a kid, a 12-year-old girl, and I find out she's a soccer goalie. This is the intake. And mom and dad are very anxious, and the kid's pretty impaired. So I start talking about soccer. Like, a lot. Angles and goalie gloves, and how do you do this, and what do you do on corner kicks. The kid was pretty sophisticated. She was a travel soccer player. And at one point, the mom looks at me. The mom's got a big watch. She looks at me. She goes like this. This is her gesture. And I'm talking to the kid. Mom looks at me. She goes, in other words, pal, why are you wasting our valuable time talking about soccer? And my response was this. I smile. I go like this. Back to the kid. I spend more time on soccer. Why am I talking about soccer? Because I need to know what she likes to think about, and I need to know what she has to lose. That's what I want. That's what I want. It may sound obscure, it may sound irrelevant. My trainees now, they sit on watching my intake sometimes. And they sit there with a manual in their hand. And no more than a few times I've heard the shuffling of the paper. So they're going back and they're going forth and they're just looking down like, where is he? What is he doing? And my response to them is this. I got you. Just follow me. I'm not linear anymore. I'm going to do what I need to do when I need to do. If I see an opening, I'm going. This kid told me that travel soccer is more important to her than anything else. Boom. Now, I got it. I want my hooks in there. And I don't want to use things that don't matter to the kid. Right? I think it was a 10-year-old boy sitting in my office. And the parents are cajoling him because he's sort of not with me so much. And the parent, I think it was a dad this time, he turns to he goes, but what about college? He's 10. The kid, I love the kid's answer. He goes, what's college? What about your 401k? They don't care. Right? Compounding interest? It's a kid. Come on. Talk kid language. What does this kid have to lose? And what do they have to gain? That's what I want. Rewards. I always love this one. Every once in a while you get a parent who say, I don't want to give rewards. Should be doing it anyway. It's the right thing to do. And my response to that is usually this. So you know what? I love my job. But the University of Pennsylvania has figured something out. At the end of the month, they should provide me with some reward for doing so. They make a direct deposit into my bank account. And I promise you, the first time they fail to do it will be the last. So we're all getting rewarded. Like, why don't we just use it in our favor? Why do we need to be so draconian? Move it along. What's a kid want to work for? What do you want to work for? We had a girl once who basically said contamination, like 40 times a day hand washing. I have no problem. It's just my parents are on my back. And my supervisor is doing the intake, Michael Kozak. He says to the girl, he says, is there anything you'd be willing to work for? And the light bulb went on. And she gave a dismissive squint, which was maybe genetic in their family too. She goes, yeah, my parents had a stupid rule. I can't get my ears pierced until I'm 12. Huh. How important is that to you? Everybody else has them. Huh. And you'd be willing to work for such a thing? Yes. I'd do anything. That was the proclamation. I'd do anything. Aha. Aha. So he brings parents in. And Michael was a very funny guy, a little bit obscure at times. He says to the parents, he goes, I need you to lend me her ears. They're like, Shakespeare, what? So, she signed up. I treated her. She wanted no part of it. She's mad at me the whole time, but she's willing to work and get her stickers that went towards her chart. And her Y box went from about a 24 to about a 9. Didn't matter. She never came around. Oh good, I'm going to get my ears pierced now. No thanks to you. And like I said, I'm good at ignoring tone. Well, I'm glad you had a delightful experience. I don't bend to that. And when you start working with adolescents, you better not bend to that. Watch your tone, young lady. No. No. Like that's how they communicate. Sarcasm. Don't make them do stuff that makes them feel like they're 38. Find a way to talk to this kid. And I never make people do anything. I had a kid one day come to my office. He was not very happy about being there. He's 12. He's got a big old hoodie on. Sits down in the chair. And he takes the little strings, the drawstrings, and pulls it. It looks like a periscope. So I got a guy, I can't even see his eyes. So he's like this. And my response to this, instead of, young man, this is disrespectful. Oh, God. Ever seen a Jimmy Dean movie? Don't do that. Like, dude, looks like you're not much in the mood for chatting. And the periscope stares at me. It doesn't move. So how about this? How about, I got an overdue chapter due. So I'm going to work on that. And you hang out over there and there, inside of that hoodie. If you want to chat later, feel free. And then he's staring at me, waiting. He thinks I'm bluffing. I'm never bluffing. I do have an overdue chapter. I'm going right now. So I open my chapter. I turn my desk, my chair away, and I'm working on my chapter. And I could feel the stare. You know what I mean? Like in a horror movie. You feel the eyes on you. I just kept working. I worked for 15 minutes. I got a couple of things done. And finally, I see a hand moving up, and he opens up a little bit. He says, I guess we could talk now. Okay. Because if I'm going to be another idiot adult to say, you must talk to me now. Do not run to your room. Don't shut the door. No. Don't do that. Wait him out. Wait him out. And I'm not saying they'll always come back either. It's not a strategy. It's a philosophy. That's a philosophy. Don't make them. Hard, isn't it? I've learned this. My 14-year-old is, let's just say, not the most diligent student. And it's 7th grade. It's the most important year of his life, so I'm told. He heard that at school once. He's like, guess what I learned at school today? Like, what? I learned that 7th grade is the most important year of my life. So did you now? Just trying to motivate kids who are going to apply to these magnet high schools in Philly. It is serious. I said, well, that's interesting. And he goes, you're going to love this part. Guess who I learned it from? I don't know. He says, the school counselor. He's just, you can't motivate him this way. Fear is never going to work with this dude. Never. You got to know who you're dealing with. So it's 7th grade. The science fair is due the next day. And science fair is a big deal. And I'm looking at his board the night before it's due. And it's like, he's got like block letters. The title is in block letters. I know what that is. He's eating the space. And his science fair project is about composting. And so the title is Composting, : it helps a rot. Giant block letters. Then there's like a couple of things here and there, and then at the end, giant block letters, Edward Franklin. Like he's eating the space, right? 48 font, that kind of thing. So finally, I look at it, and I see there's something else that's odd, which is there's a rotten apple core that's been, there's a hole poked in the back, and a rotten apple core has been tied to the middle of the board. I say, what's going on here? What you got? So it's my science fair project. I said, is there any material to go with it? Data? He goes, yeah. And I'm good, like I said, I'm good at backing up in this case. I said, well, I don't see much of it on the board. He goes, oh, it's not on the board. So you got handouts? No. No handouts. Now I'm curious. I go, so where is this information that you have? He goes like this, he goes. And instead of me being over, sort of the parent who's now going to make him a board that looks like it was made at NASA, that kind of thing. No. It's all you. All right. Godspeed, have fun. And like I cancel my afternoon appointments so I can come and watch him when he comes up the street. I'm sitting on the porch at 3 o'clock. I can't wait. And he's walking with the board. Like, how did it go? I'm tipping my hand a little bit. How did it go? He goes, went really well. I go, what? I said, it went really well? Really? Yeah. I said, did you get a grade on it? Yeah. Well, what was the grade? So now my anxiety is tipping out of here. What was the grade? He goes, got an A. Like, you got an A on that? And he looks at me, he goes, I'm a good presenter. And then one last question, I'm like, dude, before you go in, I said, because he has to show it next week at the Carver Festival. I said, you mind answering one question for me, though? I said, when you eat apples, you usually cut them up, don't you? Yeah, I don't like eating them with my teeth. I said, well, but there's an apple core there. I said, where did that come from? He goes, I found it in the street. So, I'm not going to motivate him by going heavy. He's not that guy. So you got to know who they are. You got to know who they are. If you come with all this draconian stuff, they're not going to take. Some of these kids are going to say, like, that's ridiculous. So you got to know who you're dealing with. How am I time-wise?
We have 20 minutes to break.
Fantastic. I will continue. So, implementing across the developmental spectrum. You guys getting the idea? It's the same principle, same disorder. Obsessions give rise to anxiety. Compulsions reduce it, which is a bad thing. If you're 78, that's true. If you're 5, that's true too. Just how you pitch this is going to depend on the lens of development. How am I going to pitch this? How am I going to work? Depends on where we are developmentally. What are they interested in? What do they have to gain? What do they have to lose? That's what I want. So, this is from the series called Treatments That Work, which is selling much better than the series Treatments That Don't Work. Really? Treatments that work? Anyway. So, Ed Nafola, my academic mentor, and maybe one of the preeminent people in this field, wrote this manual with Elna Yadin and Tracy Lichtner, both dear colleagues of mine. And this is the second edition of their therapist guide. So basically, it puts into more detail what I've been talking about. The kid version, March and Mule, 1998. And I literally a week ago today, submitted a 430-page revision of this. We combined both of these books. And so we basically have a new version which is very, very heavy on dialogue. So how do you talk to people about this? Because I think framing is everything. If I can tell you to do exposure. On page 38, do exposure. Page 58, do exposure. Page 78, encourage response prevention. But how? What words? And if it goes well, fabulous. What happens if it doesn't? The kid flat out rejects it. Remember how important I told you that was? Kid declines on exposure. If I back out of the room, this treatment's over. Which doesn't mean I need to go attack either. I take a couple steps back, I acknowledge their stuck position, but I'm looking to move forward. Always looking to move forward. So in all these protocols, that's what you're doing. Teaching them what OCD is and what OCD isn't. Why am I having intrusive thoughts about killing people? Well, let's go through it. My guess is, from what you've told me, in the absence of you having killed many people, my guess is you're having them because you're trying not to have them. Right? I'll ask those questions very directly. Like, what's your history? And customarily, I get, I've not murdered anybody. Okay, so you're working on the animals then? No, I love animals. So let me guess. This isn't you. You're afraid of the thoughts. You don't like them. You don't conjure them up on purpose, do you? In this day and age, you better be good at this differential. But in some ways you don't, because the base rates are so much higher for this. I like your odds. You don't sound like somebody who could or would. And I tell people all the time, I like your odds, but there are no guarantees. Same as me. I've gone 54 years on this planet without doing anything awful. Maybe tomorrow might be the day. I don't think so, but I don't seek those kinds of guarantees that you seek. And the problem is, the more you seek those guarantees, the more stuck you are at the thoughts. It's the bitter irony of this thing. We make maps, develop treatment hierarchies, low, medium, and high with kids. And with adults, you can get more nuance. But I don't like to use like 0 to 100 scales. I got away from that a long time ago. Waste time. And people are trying to be too precise. How anxious are you? I think I'm a 57. Really? As opposed to a 56? Let's be imprecise. I just moved the decimal point on you. You're a 5 or a 6? 5.5. No. I took the decimal point away. What are you? 5. But I might be a 6. This is an exposure, isn't it? So I'll ask him quick. I want you to answer this question quick. How anxious? 6. Good. Good. But what if I'm wrong? Well, it probably doesn't matter. Right? Doesn't matter. Don't get stuck on the detail. That's OCD talking. Exposure or response prevention. Confront the situations that provoke distress. Reduce and eliminate avoidance, including compulsion. There you go. There's your treatment. Start low, work your way up. Relapse prevention. For me, relapse prevention begins day 1. I'm going to tell you right now, you should not expect to have a clear, perfect mind. No such bloody thing. The mind is a bucking bronco. It's going to think whatever it wants to think. It's in many ways like fishing. Like you catch something and you decide, is this worth keeping? Oh good, it's a catfish. It's 1.5 feet long. I guess we'll have some lunch. Right? I find an old boot. I take it, all right, well, let's throw it back in. Or maybe put it in the trash if you're going to be responsible. But you see what I'm saying? You don't have to keep them all. Keep the ones that are useful. What, I had an unwanted thought? Yeah, okay. So what? Whenever I have unwanted thoughts, I always share them with the patients. I can't believe the one I had last week. Fantastic. And people are like, what? You have them too? Yeah, I get them all the time. But I don't care about them. I don't ascribe any meaning to them. I don't think they mean anything about who I am as a person. They're useful to me in my intervention, so I just collect them. Like Topps baseball cards. Like, it doesn't matter. Who cares? Why are we trying to control things we don't need to control? Right? I remember watching a profound lesson about this with my 8th grader, now my 22-year-old. Very intense. She when pitching, like the face of Roger Clemens, for those who know what I'm talking about. Just hatred of the batter. And very perfectionistic and very demanding of herself and tough on people. And we're at a road tournament in South Philadelphia. Tough place to play. And first pitch, right belt high, right down the middle. Umpire with those South Philly accent, he goes, ball 1. My kid makes a fatal mistake. She walks off the mound and she goes like this. In other words, where was that? Takes the ball back, snaps at it. Next pitch, belt high, right over the middle. And the poor girl's like, I can't hit that. Ball, he takes off the mask. He goes, ball 2. In other words, don't show me up here. And all of a sudden, she starts firing the ball the fastest I've ever seen her, but she's all over the place. She hit that batter like right in the neck. And everyone's getting hit. Just hitting people and throwing the ball over the place. Gives up like 4 runs, which is just unheard of. Comes into my dugout. Kicks down all the bats, throws the glove. And I'm coming over as a coach. I'm coming over to have a chat. Her pitching coach stops me. She's a Penn pitcher, really good. She stops me. She goes, I got this. She walks over. And she says, puts her arm around her. She says, Gwen, there's something that you don't understand. And Gwen's still, the fume is coming out of her. And she's like, what? She says, you are wasting your time trying to control things that you don't control. And that got you in trouble. So you have to control the controllables. And she says, as a pitcher, what do you control? And Gwen's like, I don't control anything. No, actually you do. You don't control the umpire. You don't control the players behind you. You control one thing. And that is your motion. So she says, come here. Before they rake this mound, I want you to look at your footprint. And Jess has taught her, every time that foot lands, it should be at 1 o'clock. Every time. She says, look at the mound before they rake it. And her foot was like 86 footprints. All over the place. And Jess is like, okay, you're going to pitch again. Only this time, the only thing I want you to focus on is that foot at 1 o'clock. Everything else, meaningless. Control the controllables, not the things out of your hands. Obsessions are not the controllables. Your response, that's controllable. So, with adults, John Abramowitz, former postdoc of ours, has been actually having spouses in sessions for a couple of years now. As a support person, as a person who can help with exposures between sessions. Looks like it's working pretty well, too. Maybe even better than standard treatment. He doesn't have a randomized trial yet. I think we're getting there. But it's interesting. People who can back you up. People who can reinforce the effort. People who can help you implement the treatment. Not a bad thing to have around. So when you're implementing with adults, customarily hour-long sessions. What did you do for homework? How did it go? Let's go do some exposure. And let's figure out what we're doing this week. Now if you have the spouse in there, then you're going to spend some time with that as well, but standard treatment, I think, still is going to be individual treatment. Typically hour-long once a week, sometimes twice a week. Talk about OCD, what it is. Give your exercises, create your hierarchy. Talk about all this stuff. And if they don't seem up for it, you talk about what else is possible, instead of trying to twist somebody's arm into doing something they don't want to do. These planning sessions, antecedents, what comes before, the exact behavior, what are the rituals, what do they look like, when do you do them, how do you do them, and what happens when you do them, what happens when you don't do them. I need to know that level of detail. The SUD scale, 0 to 10, I tend to use just to make it simple. 10 is the most anxiety you can imagine, 0 is inner peace. Okay? I teach them what I want them to do about reducing and eliminating compulsions. Talk to you about what to do instead when you're really stressed out. The moral of that story is go about your business. Find something fun to do. Go talk to people who are helpful to you. Not as distraction, but as going about your business. It's distraction. The function of distraction is to make myself feel better in the moment. That's not what we want. That sounds like a compulsion to me. I want you to go about your business. Choose what that business is. Now we're getting into ACT again. What should you be doing with your life? What should you be doing with your time? Go do that. If you're anxious, that's fine. If you're not anxious, that's fine too. I don't care if you're anxious. I said that to some adult once. He's like, I thought you were supposed to be the anxiety doc. Yeah, I am. And I don't care if you're anxious. What? Takes them a while. Okay? Again, you can if you need. And this support person is going to be positively reinforcing the behavior that's not OCD. Gentle reminders not to ritualize if they're missing something, but not yelling. I don't want compulsion police. Right? It's not helpful. It just adds gas to the fire. And emotional support in general. Not your job to make them better. You're going to help us, but they're on the field. I've been accused of this before. Not being as cognitive as some other folks are. I think I am cognitive, actually. I just think the best way to change cognition is experience. Foa and Kozak, 1986. Emotional processing of fear. Exposure to corrective information. I had a grad school supervisor hand me that thing in 1988. It was fresh off the presses. Psych bulletin. I didn't know who these people were, but I read it. I must have read it like 30 times. I could not unpack it. It took me years to figure out what the heck they were talking about. But what they were talking about was when you do exposure, you learn stuff. You said you would still be anxious after half an hour and you look like you're reaching inner peace. You asleep yet? What do you make of that? How can that be? I'm talking to them about what their experience is and whether it's consistent or inconsistent with their hypotheses. Right? So I'm a behavior therapist who's interested in cognition. And with some people, the not just right gang, especially more with the kids, cognition's not as relevant. But when I have harm avoidance and specific feared consequences, I spend a good deal of time on this. How come we're not dead yet? You just handed me a contaminated pretzel. We just went to the dumpster. Touched the side of the dumpster. You just handed me pretzels. You contaminated them. I ate them. Why am I not throwing up? Why am I not bleeding out of my eyeballs? What do you make of it? I don't know. Well, maybe your OCD was lying to you. Let's find out. Give me another pretzel. Now you try one. Hot. You bleeding out of your eyeballs yet? No? All right. What do we make of it? I'm challenging their cognition. We wrote this some years ago, Ed and I. We use informal cognitive procedures to support and augment ERP rather than replace it. Other people do it differently, and some of these methods work just fine too. This is just, I'm dyed-in-the-wool exposure therapist. That's how I learned it. If people won't do it, I may wind up doing more formal cognitive work, but I'm a hobgoblin of consistency. Let's go find out. Let's go, let's do it. Same way I coach. Let's go. Keep going. Good job. Good job. Keep going. Good job. But I do talk about this. Rebound effect. White bears. Anyone watch Chicago Med? They did a depiction of this recently. Right?
The knife?
Yeah.
Yeah.
They did. She did an excellent job of talking about this. She really did. She jumped the gun, pardon the pun, in terms of the exposures. I would have waited to do that, but I would have done the same exact thing. She kind of blended imaginal and in vivo exposure, psychiatrist. And what I say is, to slap it into an hour-long show is hard to do. But suffice it to say that she's doing the right stuff. So if you think you're not killing people because you're getting rid of your thoughts, we ought to get rid of that step and find out. What? I had an adult once come into my office and she was terrified of harming her boyfriend with an axe. She had all sorts of other ways she could harm him, but she's worried about that. And no history whatsoever, a kind, gentle person. Like, well, we ought to get an axe up in here. She's like, what? Let's get an axe. Bring the axe from your garage. It's like, well, how am I going to get by security? You golf, don't you? Yeah. Do me a favor then. When you come for the next session, wear a golfing outfit, stick it in your bag. We'll test it. So sure enough, she comes upstairs and her eyes are like this big. It worked. Yeah, because people aren't looking for axes in golf bags. So now I got an axe in my office. Oh, okay. He's axing me on this one. All right. So, the axe. I say, okay, well, let's find out. You got a hypothesis that if you're having the thoughts and you have the opportunity, you're going to do it. Right? Right. Good. Well, how do I have both? I want you to think about chopping me up with that axe. So she's standing over here. I have to teach her how to use an axe, too. She's holding the axe like a golf swing. Like, you're not going to kill anybody that way. Like, give me some top hand. So I teach her. Are you right hand or left hand? She's right. Okay, right. Good. I'm left, so I'm different. So I got her up like this. I'm sitting across from her. And I'm like, well, how anxious are you? She's like, 2. And she's like 5'2", maybe 110, soaking wet. I'm like, 2? Is my life that valueless? And she's like, no. You see, humor gets in here a little bit. Cut things a bit. Pardon the pun. And so I said, well, how can you be a 2? And she says, because I think you can take me. It was like 15 years ago. I kind of looked more athletic. I played football, so that's a really good point. So that's going to invalidate our exposure, isn't it? Yeah. Okay. Do me a favor, would you? Stand there. I'm going to take out an overdue chapter, which I did. I'm going to turn my back to you. I'm going to turn the screen so I don't see your reflection. And then I take out the chalk that I usually use for pentagrams and stuff. And I drew an X on my bald spot. I said, do me a favor, would you? I'm an OCD expert. If I get this wrong and you hit me in the shoulder, it's going to be really embarrassing professionally. So make sure you get me right here. And I turn my back, and she's like, I'm like, how anxious are you now? 9. Good. 45 minutes with her standing like this. And she's like, can I put the axe down? I'm like, how come? Because my arm's tired. Switch to the other arm. She's like, I'm not going to generate as much power this way. So she's getting the idea. 2 sessions later, the axe is nothing. Because she confronted him. Okay? So I'm going to stop here in the interest of time. You cut off. And we'll pick up from here. I'm going to start up the afternoon. I'll spend more time on the kids. Okay?